So I'll just do your introduction. So if you want to set your slides up ready so that you can follow on, that would be great. So our next speaker is Associate Professor Leanne Chapple, who's the Senior Critical Care Dietitian at the Royal Adelaide Hospital and Research Fellow at the University of Adelaide in Adelaide, Australia. She leads the Intensive Care Nutrition Research Programme at the Royal Adelaide Hospital, conducting research focusing on nutrition physiology during critical illness and early recovery. In particular, Associate Professor Chapple has an interest in improving nutrient digestion, absorption and utilisation to prevent muscle wasting and improve recovery for critically ill patients. So I'll hand over to you, if that's okay.
Thank you, Amy. Now, this isn't letting me share my screen because I need to update Teams, even though I did this just recently. So I did send my slides through if someone's able to share them. Let me know if that's not possible.
Bear us 1 minute, we'll get that sorted for you.
No worries, thank you. Wonderful.
Hi, this is Emma. Just checking you can see that.
Yes, that's perfect, Emma. I'm guessing you'll have to flick through for me as well. So I'll try and give you some indication so I'm not saying next slide every 5 seconds.
Not a problem at all.
Thank you for that. So I am going to be presenting on delayed gastric emptying. I feel like I am probably not the best person to be presenting to the British group because you are so well in front of us when it comes to extended scope of practice, but I do come from a unit that has a lot of access to different techniques, and I'll be going through most of the methods associated with that. Thank you. You can flick on to the next one if that's okay, Emma.
Bear with me a moment, it's not working.
There we go. So I don't have any conflicts of interest, but I do have a little bit of support that I thought would be worth mentioning when we're talking about nasogastric or nasojejunal tube insertions. So I do have an NHMRC fellowship that supports my salary that finishes at the start of next year. I've also done some advisory and consultancy for Avanos, and we have had our core track equipment upgraded from them recently. And I've also received some research funding from Cardinal Health as part of their Kangaroo Iris tube placement. We can skip the next one if that's okay, Emma.
So I've just got a bit of a delay. Bear with me a moment.
So the next slide you'll see is showing, I guess I'm going to be focusing on ICU, given that's my background, and hopefully a few of you are ICU dietitians or health professionals. So we need to know that ICU patients experience GI dysfunction all the way from upper with nausea and vomiting, down through delayed gastric emptying, intestinal dysmotility, down to diarrhea and constipation. So we can skip the next 2. So we're going to be focusing on delayed gastric emptying as part of this presentation. So we do know that around 50% of critically ill patients have delayed gastric emptying. This graph here from Marianne Chapman, who was one of my PhD supervisors, shows that ICU patients really have very varied gastric emptying. This shows the percent retention of a meal after 240 minutes, with some patients retaining 100% of that meal after that time, all the way down to complete emptying, as we see in healthy subjects. So it's very varied, but around half have delayed gastric emptying. Sorry, this is going to be painful. The consequences of delayed gastric emptying, I'm sure many are aware of, so associated with reduced nutrient delivery, increased risk of aspiration, which can lead to an increased risk of pneumonia, and that is also associated with higher rates of mortality. The causes of GI function are really broad. So focusing on delayed gastric emptying is the little yellow boxes up in the top, where we have decreased fundic waves, reduced relaxation and slow tone regaining. And then we also have impaired gastroduodenal motility and increased pyloric tone. We also have enhanced small intestinal feedback. So that means that any nutrient getting through the intestine sends a signal back to the stomach to further slow down. And that's exacerbated in critical illness. So we get a constant cycle of delayed gastric emptying further exacerbating itself. In terms of risk factors for delayed gastric emptying, this paper really goes through a lot of the associated factors. It was a retrospective review conducted at the Royal Adelaide Hospital in 132 unselected mechanically ventilated patients, of which 60% had delayed gastric emptying. And what this showed in terms of the types of admission diagnoses associated with it, gastric emptying was most common in patients that had burns injuries, with 77% showing delayed gastric emptying, followed by multi-trauma and head injuries, so cerebral injury. 60% of patients with sepsis also had delayed gastric emptying, all the way down to the non-GI post-op respiratory failure or cardiac injuries in around a third to half, a quarter of patients. So those really multi-trauma patients are the ones we see with greater delayed gastric emptying. Delayed gastric emptying in this study also was associated with an older age, higher admission Apache 2 scores, so the sicker the patient, the more likely they are to have delayed gastric emptying, longer ICU stay before the measurement, and that's probably correlated with injury severity as well. It's also delayed gastric emptying was higher in patients with a higher respiratory rate, higher FiO2 and a higher serum creatinine. So what strategies do we use to manage delayed gastric emptying? So the first strategy that some of our maybe medical colleagues may use as a first resort is to just give less nutrition. Obviously, speaking with an interest in nutrition, that's not something that we advocate for, but it is sometimes a strategy used in the short term. Another option is to deliver prokinetics. So there are a number of prokinetics available. The most common ones that we use, definitely in Australia, erythromycin, which we know accelerates gastric emptying, and metoclopramide is known to increase lower esophageal sphincter tone and stimulate gastric contractions while relaxing the pylorus and duodenum. So they have different modes of action that work well together. The next slide will show that this study showed that when you actually provide the prokinetics together, they're more effective. So if you're providing a single prokinetic, the effectiveness decreases to a third after 72 hours, whereas when providing dual prokinetics, so metoclopramide and erythromycin in the doses shown there, it sustains the effect of either drug given alone. So that's our first line of therapy in our ICU in Australia. Another strategy that is probably a little bit more historical, and I'm not sure of the practice in the UK, but often in Australia people move on to a concentrated formula in the thought that providing less volume into the stomach may help reduce delayed gastric emptying or sort of help with that. This study that I've put up here, we actually compared a standard versus an energy dense formula when they were matched by calories. So it's 200 mils of a standard formula and 100 mils of an energy dense formula. And what we found was that they actually emptied at a similar rate, with the standard formula actually emptying a little bit quicker with the larger volume. So while you may get a smaller GRV with a concentrated formula, the actual delay or gastric emptying will be the same, and the amount of nutrient reaching the intestine will be similar between the two feeds, if not better, with the standard care. So this is something that we don't tend to do as frequently in our ICU unless they need a concentrated formula for a different reason, such as fluid status. And then post-pyloric feeding. So I won't talk too much about this, so we can move through these slides relatively quickly, given that the following speakers are going to focus quite a lot on this. So we do know that post-pyloric feeding is associated with improvements, so less reflux vomiting and ventilator-associated pneumonia than nasogastric feeding. And the further the tube is placed distally, the more likely or the aspiration risk declines. So the further along, the better. This is supported by international guidelines. So the European guidelines showed a trend for less pneumonia with post-pyloric feeding, and then hence recommend that if patients are at high risk of aspiration. And the Aspen guidelines on the following slide looked at 13 randomised control trials that also showed lower rates of pneumonia with small bowel feeding. Hence, they recommend using post-pyloric feeding in patients deemed to be at high risk for aspiration. When we're considering those at high risk of aspiration, this consensus statement from North America Summit shows what they consider that to be, and basically it's every ICU patient. So inability to protect their airway, mechanical ventilation, or reduced level of consciousness. So we have to be a little bit more savvy in ICU about which patients we think may actually benefit from nasojejunal feeding. So how can we measure gastric emptying? And this is going to be the bulk of my talk. So there's a number of different techniques. This comes from a paper by Palash Kar, who was a PhD student in our unit a few years ago, where he looked at the different types of measurements. So scintigraphy is a measurement that directly measures gastric emptying. There's a number of indirect measurements, such as paracetamol absorption, isotope breath tests, and ultrasound, and I'll go through these in more detail. And also a surrogate outcome being gastric residual volumes that tend to be used in clinical practice. So the first measurement is scintigraphy. So this is considered the gold standard measurement. On the next slide, you'll be able to see how this equipment works. So this is a portable gamma camera. It's one that we have in our unit. They're quite expensive, so around 250,000 Australian dollars. The equipment has a camera inserted, so that sits over the patient's belly. It is portable, so we can place this in the ICU room if it's big enough, and that connects to a computer screen where we can actually monitor the images taken. So on the next slide, at the bedside, we deliver a radioactive label, so that's mixed in with the feed and can be delivered via the nasogastric tube. And almost immediately you can see that radioactive label being pictured on the associated computer. So the gamma camera can take images of the stomach region at predefined intervals, which are set up prior to the study starting. So we tend to do 1 to 3 minute intervals over a 4-hour period. And we chose 4 hours because that tends to be, by that stage, most of the patients will have emptied at least some of the feed from their stomach. The images are then saved for later analysis. Once we have the images, our nuclear medicine technicians sit down and draw regions of interest around each of those images. So you can see the one in the picture there shows the yellow is the middle of the stomach and up towards the esophagus. So we can look at things like proximal versus distal stomach as well. And then from that GE or gastric emptying curves are derived, and we can calculate the percent retention, so how much feed is left in the stomach over a given period of time, and often T50 is chosen as a comparable time, where we're looking at the time point at which 50% of the contents is emptied from the stomach. So these images here show what normal gastric emptying looks like along the top, where at T0, the full feed is sitting in the stomach, and by 300 minutes, you can see most of it's moved down through into the bowel. Whereas the bottom row shows the slow gastric emptying, and this is what many of our patients look like, where at T300, most of that feed is still sitting within the stomach region with only a little bit having moved through. So the pros of scintigraphy, obviously it's the only measurement that provides a direct measure of gastric emptying, so it's a very strong pro. But the cons are it's really not available to many people. So it does require specialised equipment as well as technical staff. So it involves a nuclear medicine unit to provide the radioactive label to be delivered in ICU, and also technicians to analyse the images, which is quite time consuming. And because of that, it's very expensive. There's obviously the requirement for the radioactive label. We use a label with a very short acting or short half-life, so that by the time that's moved through the whole patient's system, the label has moved off. Otherwise, we'd be collecting faeces and disposing of that. But there is always the risk of the patient vomiting, and we have to have standards of how to manage that. The patient position needs to be maintained for the study duration, so for the 4-hour period, and that comes with risks associated with pressure, injury management. It's also time intensive, having someone standing next to the camera. Obviously, only some people can operate it, and we need to be there in case something goes wrong with a patient. We have to move it off quickly. And you can only assess gastric emptying in response to a bolus feed. So we're unable to test the response during continuous feeding, which is how most units feed their patients in ICU. So at the end of each of these sections, I'm just going to put up some examples of studies that do use these techniques. Most of them come from our unit, but there are many other units that do use these techniques. I'm not going to go into the studies in detail, but it just gives you an option to look up another resource of paper that has used them. So we can move on. So going to the other end of the spectrum now, so the gastric residual volumes or gastric aspirates. So this is a technique that's used clinically. I'm sure you're all aware that a GRV is the amount of liquid drained from a stomach following administration of enteral feed. That liquid consists mainly of infused nutritional formula, but also water or secreted gastric juices. And it's usually checked at routine intervals, often in today's standards around 6 to 8 hourly in critically ill patients. The pros of GRVs are that they are inexpensive and can be performed at the bedside. They can track change in individual patients. They're also available universally, whereas many of the other techniques aren't. And they have been shown to correlate with scintigraphy and breath tests in some populations. The cons are that there's some lack of association with outcomes, particularly a low sensitivity for aspiration risk. It does not just quantify EN, with gastric juices being included in that, and how that's managed is not really clear. There's no agreed cut-off threshold, so there are some studies that compare things like 250 versus 500 mils, but there's no agreed rate for that. And it's affected by many different aspects. So the method of drainage used, whether that's sort of gravity or suction, body positioning, the amount of gastric juice that that individual patient produces, the type of tube, with fine bore being more difficult to suction, so often GRVs through a fine bore are inaccurate compared to a wide bore, and the position of the tube tip in the gastric body. So it's something that I do tend to look at, particularly if patients are showing other signs of poor tolerance of feeds. Is the tube tip sitting in this just below the esophageal junction, or is it more distal? So the guidelines around GRVs, I won't spend too much time on, but the American guidelines do suggest that GRVs not be used as part of routine care. And they suggest that if you are using GRVs, that we shouldn't hold EN for GRVs less than 500 mils in the absence of other signs of intolerance. And this is a way of trying to prevent fasting or reducing the amount of feed delivered to patients. These are based on low quality of evidence. The ESPEN guidelines that are a bit more recent say that the measurement of GRVs is common and they may help identify EN intolerance, and they say particularly during initiation of progression. They think that monitoring of established EN with continued measurement may not be necessary, and they do recommend that if we are using GRVs that we should delay enteral feeding when the GRV is more than 500 mils when it's tested every 6 hours. This is a new Cochrane review that I have just come across as part of this talk that provides a lot of data and reviews of the studies looking at all aspects of GRVs. So I've just put this up there as something to look up. So it does compare frequency of GRV monitoring, no monitoring compared to GRV monitoring, looking at the type of threshold that we use, and also comparing returning the GRV compared to discarding. The studies that tend to use GRV as a technique of looking at feed intolerance tend to be these larger scale studies. So this is a target trial which recruited 4,000 critically ill patients. And given that it was asking many ICUs to provide data, it did collect data that was routinely used clinically. So as that study, they looked at the median largest gastric residual volume as a sign of intolerance. So the third test that I'll be talking about is a paracetamol absorption test. This is probably the only one that I have not used myself, given that we have access to a range of different tests in our unit. So this method relies on the use of an ingested drug that's not absorbed in the stomach, but is absorbed in the small intestine. From that, we can measure the concentration of that particular drug in plasma samples, and it can be reported as a peak concentration, time to peak concentration, or area under the curve. Studies do use a range of different reporting techniques, which is one of the difficulties with this technique. So the pros are that it's inexpensive, it costs the Panadol and the measurement of the laboratory test to test that level, and often that is something that's available for ICUs routinely. It can be performed at the bedside and it's safe and simple to perform. Some of the challenges are the pharmacokinetics may be altered in some patients with critical illness, particularly in those with liver impairment. It's not accurate. It does require a baseline concentration of paracetamol to be 0. So if we're using it as part of clinical care, then those patients can't have their gastric emptying measured using that technique. And there's also no standardised protocol. So what dose is provided or the form of paracetamol used isn't standardised in the literature. And there's different methods used to calculate the gastric emptying from those concentrations measured. So it does mean that when we're comparing studies that use this technique, it can be quite difficult. So the next test, the studies that use these techniques. So the first one there by Tarling is one of the first studies that looked at this in intensive care. And then a few other studies, particularly from Paul Wishmeyer's group, have used this technique to compare different prokinetics in facilitating gastric emptying. The next technique is looking at breath tests. So there's a number of different types of breath tests that can be used. The one that we use in our centre is the 13C octanoic acid breath test. So this is where the octanoic acid isotope is added to the formula and octanoate is emptied into the intestine and absorbed. That's subsequently metabolised to 13CO2 by the liver, which is exhaled, and we can collect that in a breath sample. So the image here, you can see we place a little T tube or test adapter into the ventilator circuit for our ICU patients connected to a vacutainer, and through that we can connect on the breath test anytime the patient is exhaling when we need to take the measurement. So the breath samples are collected usually at quite frequent intervals, normally starting at 5-minute intervals, and that can be analysed for 13CO2 concentrations. From that, they can calculate a gastric emptying coefficient, and a delayed gastric emptying is defined as a gastric emptying coefficient of less than 3.25. So the lower the GEC, the more delayed the gastric emptying is. And we can also look at the gastric emptying half time, so similar to what's used in scintigraphy, where delayed gastric emptying is defined as more than 140 minutes. The benefit of this technique is that it can be used in both self-ventilating and mechanically ventilated patients. And some of our studies can actually then follow patients up using the same technique where we use the T adapter in ICU, and then once the patient has regained the ability to breathe on their own, then they can blow into the tube through a straw and we can collect the breath that way. This technique's also been shown to correlate to some scintigraphy on a group level. So it's useful in crossover design or assessing the response to therapy, and it's more relevant to research than individual practice for that reason. It also has less interference on patient care in that you just have to collect the breath sample, but there's no equipment that needs to be on the patient during the test. Some of the difficulties with this measurement are that it is expensive. So it requires the frequent sampling for an extended period of time, so it's quite time consuming, and then the testing is normally done in a specialised lab using isotope ratio mass spectrometry. Its use is also limited in marked gastroparesis, so it's difficult if patients have really severe delayed gastric emptying. The studies that use this technique, so this is one that I did looking at appetite and nutrient intake 3 months after ICU discharge compared to health in ICU survivors, where we looked at gastric emptying using the breath test in both those populations. The fifth measurement that I'm going to be talking about is carbohydrate absorption. So the carbohydrate absorption test uses a 3-O-methyl glucose, or the 3-OMG, which is a fun acronym. This is a synthetic glucose analogue that's impermeable to gastric mucosa, but absorbed in the small intestine. So what that means is that the appearance of the 3-OMG in plasma or the blood samples is equivalent to the rate of absorption from the small intestine. So the 3-OMG concentrations can be measured in blood samples over time and a total area under the curve calculated, with higher values indicating improved intestinal absorption. This is slightly different to the other techniques here in that while it does give an indication of delayed gastric emptying or gastric emptying time, it also looks at absorption is measuring the plasma sample, the absorption from the small intestine. So it gives an assessment of both digestion and absorption. Because of that, it's often used in conjunction with the breath test, so then we can sort of differentiate between the digestion and the absorption times. The pros of this is it does measure digestion and absorption, and it's relatively simple to do in that you put the 3-OMG in with the formula and can deliver it at the bedside. Some of the cons are that it's expensive, so the 3-OMG itself, as well as the testing using high performance liquid chromatography, is expensive. It requires frequent blood samples, which is obviously a concern in our ICU patients, and it can be affected by the pharmacokinetics in critical illness. So one of the studies that uses this technique is one of my honours students, James Whitehead, who looked at delayed gastric emptying or gastric emptying in ICU, on the post-ICU ward, and also 3 months after that. So one of the final techniques in this space is the ultrasound of the antral area. So this is probably a newer technique or used a little bit less frequently, where we take an ultrasound of the gastric antrum or the antral area. This can be measured in response to a solid meal or liquid, with serial measurements used to form a gastric emptying curve, and then a mathematical formula can be used to determine the volume from a cross-sectional area. These images here are some of the best I've found in the literature, showing the empty stomach at the top. So you can see the LLL is the liver, the A is the stomach or the antral area, and usually it is quite clear to see, particularly when it's empty around the antral area. The P is the pancreas, superior mesenteric artery, and you can also see the aorta. So when we take these measurements, particularly doing serial ones to measure gastric emptying, it's really important those anatomical landmarks are clear. Often the antrum itself is difficult to see, but once we find those landmarks, then we can get a better idea of where that sits. You can see that depending on the meal provided, it can affect the quality of the images being ultrasound. So a clear fluid, you can see that the antral area is expanded there and it's quite clear within the stomach. Whereas when we've got milk delivered in the bottom left-hand corner, the fat content within that can cause an opaqueness to the scan, and that can make it very difficult to see the antrum. And you see the same in the bottom corner with the solid meal having the fat content in that. So the pros of this are it's inexpensive when you have access to clinical ultrasound equipment. It can be formed at the bedside, and it may be most effective at assessing a full versus an empty stomach. So some studies use this to just check if the stomach is empty prior to theatre. And it could be used to assess gastric contents during continuous feeding in clinical practice, compared to most of the other techniques that can't do this. Some of the challenges associated with this technique is it is user dependent. It does take some training and trialling on different patients' anatomy. There's some post-measurement analysis that is required if we want to look at gastric emptying using this technique. It can be challenging to view gastric emptying of lipid-containing liquids like enteral nutrition, and any presence of gas or air can also affect the ultrasound. So this is something that's quite common in our critically ill patients, so it does make it challenging. There's also no threshold or defined threshold for delayed gastric emptying using this technique. So there are a couple of studies that have used this. It's quite often used in the paediatric ICU space. So you can look those ones up there. So just to finish off, there are a couple of newer techniques that I've come across more recently. So the first one is by Art Medical, who have been going to a few of the more recent conferences. So we might skip the next one and move on to the one after. So basically this is a all-encompassing, sorry, the one before, all-encompassing equipment where it has a nasogastric tube that's connected to a console, and that nasogastric tube has a sensor built into it. It also has a small balloon within that tube that once any sort of gastric juices or liquid from the stomach is sensed higher up on the tube, so towards the esophagus, that balloon can actually inflate and can prevent the gastric juices from, or any of the GRV coming up into the esophagus. There's also then a port that can remove any of the higher amounts of gastric emptying from that. So the next slide, I've only got a couple left, is using transcutaneous fluorescence spectroscopy. So the next slide shows that this uses a fluorescent, let me get there, an oral dose of one or more fluorescent contrasts is administered, and then a wearable fibre optic probe can be used to look at the presence of those in the bloodstream. And the rate of the uptake of the fluorescent dye can indicate the rate of gastric emptying. So on the next slide, we can see that this hasn't been used in ICU. It's really just some first clinical experiences in healthy volunteers as yet. I think that's my final slide. Sorry if I've gone a little bit over time. This review just goes through a lot of the information that I've discussed today. So it's a really comprehensive review by Palash Kar that would be great to look up. And I'll finish with the conclusions there.
Fabulous. Thank you so much. You've gone through that really in depth, and I think I'll have to catch up again, rewatch it. We've had 4 questions through in the chat, so we'll just spend 5 minutes for your Q&A if that's okay with you.
Yes.
The first question is, in the Chapman et al. Study, what was classed as a meal for the gastric emptying?
Yeah, so most of the studies that we've done in our unit tend to use 100 mils of an enteral formula. So previously we would use Ensure Plus as the standard, and we've used that for most of our studies until that specific formulation was changed. So we did try and keep it consistent so we could compare between groups, but most of the time it would be a 1 kilocal formula, and we normally give 100 mils because we find that's quite well tolerated and can be emptied over the period of time, so the 4-hour study period.
And then the next question is, can you please explain the study involving the standard versus 2 cal? Did you say that both empty the stomach at similar rates? So therefore, is it better to use 2 cal for better energy protein provision if at the same rate?
So they actually emptied in a volume way at different rates. So the 2 cal emptied slower. So they actually emptied based on a kilocal, which is what we know from health happens. Sometimes with a larger volume that can push the nutrient through quicker, which we found in that study. So the 2 cal emptied slower than the 1 kilocal, but the nutrient delivery was similar. So the amount that reaches the intestine.
Okay. And then the third one is, what is delayed gastric emptying defined as when using scintigraphy in critically ill patients?
I actually don't know now, and I'm not sure if there's a defined cutoff. I think it might be similar to the GEC. I don't know if it has the same specific sort of cutoff values like that does. Often it's used to compare between groups, but I'll have to look that up. That's something I should know. Apologies.
No, that's fine. It's more than I know. And then the final question was, do you need to administer 3 OMG to measure small intestine glucose absorption? Is there a way to measure glucose absorption simply from the administration of enteral feeds or a plain glucose solution?
Not that I'm aware of. I think you do need to have something that's labelled. Because yeah, you definitely have to have something labelled to then be able to measure it at the end point. So unless someone's heard something else and Terpsy may have, then yeah, I think you have to have a label.
Okay, perfect. Just checking that all the questions, there's none more come through in the chat. So I thank you again for joining us for all the way from Australia. Your talk was fantastic.
Thank
And
you.
I'll pass over back to Rebecca for our next